Good afternoon, and thank you very much for being here still at this time. In this paper, we're going to present an overview of the results that we have obtained so far in palliative treatment of painful bone metastases using the magnetic resonance guided system in Spain, in our site in Seville. So, should I press the back button or the forward? Okay. Let's see. Yeah. Our site is a joint consortium combining a university group, which is the one I'm representing. I myself am a physicist talking about new subjects in this area, as the previous speaker was saying, and a professional group coming from the medical imaging community, and a business group, which altogether have combined into this Instituto Cartuja institution at the Scientific and Technological Park in the city of Seville in Spain. Currently, we have the only MRgFUS site in Spain, and we are treating uterine fibroids. We already have about 50 cases, bone metastases, 8 cases that we are going to discuss in these minutes, and we are about to join the breast cancer clinical trial. In the very near future, within a few months, Instituto Cartuja will be opening a new hospital at the Scientific and Technological Park in Seville. The equipment is an exablate system by Insight Tech within a 1.5 Tesla MR by GE. And our research and development activities are being carried out within the framework of a new laboratory for non-invasive technologies for tumor treatment that we have all together put into operation. This laboratory combines a scientific and technological area at the labs of the Department of Applied Physics at the Engineering School of the university and the clinical activities at the Instituto Cartuja site. From a more clinical point of view in this presentation, we present the results of our first 6 cases. In the time since we submitted the presentation to be considered for this symposium, we have already treated 2 more patients, so we currently have a total of 8 cases, which are, of course, selected upon the basis of a detailed clinical evaluation, a careful patient selection, based on imaging studies, and in what refers to pain measuring and evaluation, we adhere very strictly to published standard criteria, including, of course, the scale for pain evaluation, which has already been discussed, and with a very detailed follow-up procedure, which include this more or less standard timing. And we also have had some cases in which follow-up was a little bit more frequent, and the longest follow-up we have is about 9 months in one case. The primary tumors we have been treating are, as it can be seen here, with several origins. In the case of female patients, they were all breast cancer, and in male cases, we had 2 bladder cancer and 1 colorectal. Age range was in the 60s and 70s of the patients. And we are going to see briefly a couple of examples from our experience. In this case, this was our first patient. This was a colorectal primary tumor with a treated metastasis on the ribs. Pain level before treatment was the highest, was 10/10. And what happened after the treatment? This was the patient evolution. Some of the data of the sonications are shown here, but what is really important for us is that the patient show a very, very sharp decrease in his level of pain, with a small increase approximately 1 month after treatment, which and therefore remain with this very low level. In this second case, we can see the soft tissue mass within the sacral area with bone destruction due to a urothelial carcinoma of bladder. As I haven't mentioned it explicitly, sorry, but in this part of the slide you can also see the concomitant treatment and some of the details of the chemotherapy that the patients were given. In this case, the level of pain was also very high. The location of the treated metastasis was in the coccyx, and the evolution was extremely positive. As we can see, the patients remain asymptomatic during the follow-up. And these are the type of examples that we are experiencing. Of course, this is a very promising area, in which, however, some of the circumstances sometimes make it a little bit more difficult. In this case, was a female patient with a primary breast carcinoma with those metastases, which are indicated here. And we treated one sacrum and one pelvis lesion, which in the previous images saw the osteoblastic damage in the coccyx. What happened with this patient was, as you can see in this figure here, that the pelvis, the smaller lesion, which was almost completely treated with the focused ultrasound surgery, remained within a very acceptable levels of pain, with showing a sharp decrease of 3 points in the scale. However, the sacrum lesion, which was much broader and wider, in which only a small area could be treated, show a nice decrease during the first month, but then a sharp increase back again to the previous situation. In the next case, which is also a female patient suffering from a primary breast carcinoma, the bone metastasis was in the femoral neck. We can see here that this was only one lesion, and in this case our team decided something very interesting, which has already been mentioned by the previous speakers. We tried to perform some type of ablative treatment additional to the palliative treatment of the lesion. And which were the results? The results are as follows. The results were really good for the patient, because the patient reduction was achieved within the standard, more or less, follow-up of 3 months. By then, the patient was asymptomatic, and she felt, and she still feels so good, that she restarted doing physical exercise. And due to that physical exercise, she has very recently experienced an episode of overload, which has produced her a small increase in the level of pain. It's important to note here that right after the treatment, we had an initial increase in the level of pain, which was due to the edema produced by the ablative treatment that we tried to apply to obtain in this case. The overall status right now is very good, because she is, as I was mentioning, asymptomatic. Just to finish, an overview of our cases is as it's shown here, which agrees fairly well with the graphs that previous speakers have shown us. 4 over 5 of our patients remained unpainful after 3 months in a 3-month follow-up, and the 2 cases which show an increase in pain were the ones I previously mentioned. The analgesia is the key point to prove that the level of pain is strongly decreasing, because we can see here that in these cases, the analgesia was reduced to 0 after the FUS treatment. 4 of our 6 patients ceased medication, and the level of pain, as we said, was really, really decreased. And then just to end this presentation, I'm bringing you here this review paper that we have just published a month ago in the European Oncology. It's a review paper on the applications and of early results of application of this technology. And just to finish, I would like to mention that our site, our combined site, is strongly working in the areas of non-invasive surgery, as I have mentioned, but also in molecular medicine, combining the potential of these 2 novel areas of development, which are based on the concept of first in human and dose on demand, which, in our opinion, will define the personalized medicine, which is the future and the best option in the years to come for our patients. Thank you very much for your attention.
So we have a question back here.
It's actually a question for all the speakers. I don't want my question to diminish the importance of what I see here in terms of patients who have failed radiation or aren't eligible. It's wonderful work. My question is about something Dr. Pfeffer had, as well as something Dr. Hurwitz mentioned. If single fraction SBRT is as effective as 10 fractions, for example, RTOG 9714, and there was something on a slide about MR-guided focused ultrasound being lower cost, what do you see in terms, if 5 years, 10 years down the road, we're looking at primary, where we can assess the greatest number of patients, address the greatest number of patients, what do you see the challenges for this technology in overcoming a hurdle where, okay, maybe you have a Trilogy or a Electa machine that costs a couple $1 million bucks. Maybe you have an MR-guided focused ultrasound machine that costs a couple $1 million bucks. Is it cheaper?
Right. Well, a couple issues. One is accessibility to the technology. You know, we've seen this with hyperthermia as well. There are far more linear accelerators out there than MR-guided focused ultrasound systems. You know, that will gradually change over time, but I don't think we're going to see thousands and thousands of systems out there in the next 5 years. So that's going to be a key limiting factor. There's the reimbursement issue, which is a stark reality. You know, ultimately, in terms of acceptance, there is a phase 3 trial moving forward, and I think that's going to be a very important trial to establish the role of upfront treatment with MR-guided focused ultrasound.
Yeah, I agree. The phase 3 trial is going to answer most of the questions, will scientifically answer most of the questions you ask and we all ask. How does this compare to radiotherapy, which is the standard of care? And hopefully in a couple of years' time, we'll have the answer both as regards pain control, tumor control, and cost, which we're factoring into looking at in the study as well. Another point I want to make, in the future, people are talking now about MR simulators in the radiotherapy suite. If in 5-10 years down the road, we're all going to have an MR simulator in the radiotherapy suite, it'll be very simple to incorporate this as one of the possible treatments in the radiotherapy department as a part of integrated radiotherapy department.
Okay. Thank you all for your attention, and to our speakers as well.